Now we are going to focus on this part of the management table, that is the potassium replacement and insulin therapy. Now this portion of the chart needs to be managed according to the potassium levels. The serum potassium levels are to be assessed for this portion of management, and depending upon low, normal or high potassium levels, we will have to supplement potassium along with insulin SOS needed. Now we all know insulin is a car, isn't it? Now this insulin, what it does, it pushes potassium into the cells. Carries potassium into the cell. So for the management of potassium, to lower its blood levels and to push it into the cells, we will need insulin. So when the blood levels of potassium are high, in those cases we have to give insulin. When potassium is low, we have to give potassium, isn't it? This is very normal to understand. When potassium is low, you give potassium. When potassium is high, you give insulin so that potassium moves inside the cell through the scar. In high potassium, we cannot give potassium. And when the potassium level is normal, you can give both potassium and insulin. Now this is very easy, and there is not much of understanding for this, but still I have a mnemonic for this, and that is this pot. For pot, always to symbolize potassium, I use a pot. Now this is a water pot which has water. Now when there is little water in the pot, when there is very little water in the pot, then we have to add water to it to make it more available to people. So what is that water? Potassium. When the potassium is less, we will add more potassium to the pot. When it is normal, this is the normal level of water, now that is okay. So you can add a little bit of potassium along with sand. No issues will happen because this is adequate. So you can give potassium and insulin together so that the balance is maintained. But if potassium is flooding out to absorb the potassium, that is flooding, and it will overflow from the pot. So to keep it under check, we will add sand to it. And what is that sand? Nothing but insulin. So we have to remember that when the potassium levels are low, when water is low, you give water, and when water is high, you give sand to absorb the water so that it doesn't flow. And what is that sand that absorbs water? That is insulin. So insulin is given in cases of hyperkalemia, and potassium is given in cases of hypokalemia. But for normal levels of potassium, we have to give both potassium and IV insulin for a balanced management of DKA. This is to be remembered. Now, one important thing that we have to remember is potassium. See, we were relating potassium to water pot and water. So always ensure when you're giving potassium replacement, the urine output has to be adequate. We all know that it should be given in a patient where the renal urine output is 0.5 ml per kg per hour. We cannot give potassium in renal failure patients. They will be landing up in a very grave situation. So we have to ensure before potassium replacement that the urine output is 0.5. You have to give water only when you know water will not clog inside the body. There should be a drain which will outpour the extra water. So when the outpouring is okay, that is the kidneys are normally functioning with a normal urine output, only then we can give this water or potassium replacement. Next important point that we have to remember is at what rate are we going to add this sand or the insulin that we were talking about. Okay, we will start with point 1 and we will go up to 1. Now, one you go by increasing 1 unit per hour. So we will start with a dose of zero point 0.1 units per kg per hour, and it is to be increased by 1 unit every hour till the time the DKA gets resolved. That is all the criterias of anion gap and that we had studied about the pH, they all get reversed. The anion gap, which was more than 12, becomes less than 12. The pH, which was less than 7.3, becomes more than 7.3. All the criteria till it gets resolved or reversed. Or if we give a patient who is recovering and you give a rapid active insulin, a subcutaneous dose with a meal, then within half an hour to 1 hour of this dose, you have to stop IV insulin. Otherwise, the patient will get too much of insulin and will end up into hypoglycemia. So we have to be very, very precise about the rate of increase, that is at the rate of 1 unit per kg per hour is the rate of increase, and stop when there is resolution or you have given a rapidly acting insulin along with a meal. Now, coming to the other aspects of management, we all know that without treating the cause, you cannot treat anything. So, you have to identify after these two important managements. Now, you have to identify what exactly led to the DKA, and with investigations, history, and examination, we will have to fight it out and act according to the triggering factor. Now, monitoring of the patient is very, very important. How do you monitor the blood glucose and the ketone levels? So, if you can see this beautiful, sugary, sweet girl, a single girl signifies that the sugars have to be monitored every 1 hour till it is stable. The keyboard or the ketones, they have to be monitored every 1 hour initially, but later you can make it 2 hours. See this girl, initially she has one keyboard. Now she will become a great musician, she will earn more and she will own two keyboards and two ketones and she can be a music teacher. So she starts with one ketone or keyboard and then she will own two. This is how I remember it. And other factors, that is the electrolytes, creatinine, pH and blah blah blah, other factors, we have to measure them every 2 hourly until stable. Since the glucose and ketone were the most important factors, we are mostly measuring them every hourly. And remember the baby who was very, very sad because of the condition of the mother. This baby, this baby needs to be assessed. And we assess the baby through CTG, through ultrasound, confirm viability, and we might also need to deliver the baby if the need be so, according to the findings of the baby assessment. Now, after we have known about the fluid management, the potassium management, and all of that, what it is that we have to remember is the resolution criteria. This is just the opposite of the diagnostic criteria. There the anion gap was more than 12, here it is less than equal to 12. There the bicarb was less than 15, here it is more than 15. pH was less than 7.5, now it is more than 7.5. Ketone levels of 0.6, ketone 0.6 millimole per liter is what is a new thing. Otherwise, These are just what we have already studied in the diagnostic criteria. Along with that, the vital monitoring and the urine output is something that we have to see. So, monitoring a sick patient is not something that we have to read from a chart. We know about it, that we have to read it. But what I want to impress upon in this table is this section, because when the potassium levels are low, we know that we'll give potassium. When they are high, we know we will give the vehicle to move the potassium into the cell. But when it is normal, we have to give both water and sand, that is potassium and insulin in decay is something that we have to remember. So if there's one volatile portion in this entire table, then I would say it is this portion. So please try to remember, when there is adequate potassium, we have to give both for the balanced management of DKA. So this is all about the management. Also, one more take home message is the resolution criteria of less than 0.6 millimoles per liter of ketones in the blood is something that if you can remember is going to be really helpful. Thank you.